I am Dr. Deepak Chaudhary, Principal Director and Head Department of Arthroscopy and Sports Medicine at BLK Max Hospital, New Delhi. I will be speaking today on meniscal repair, horizontal types of tears. The horizontal tears, till a few years back, they were considered irreparable, and the usual treatment was resection of either the superior or the inferior unstable flap. This frequently resulted in osteoarthritic changes. But now, with the latest implants and better techniques and better understanding of the biology, the horizontal tears are now amenable to repair. So why repair the meniscus? Because meniscus has very important functions of load transmission. They minimize the contact stresses. They contribute to stability and are chondroprotective. So what are the effects of meniscectomy? If you do a partial meniscectomy, it results in a 65% increase of contact stresses. And if you do a complete meniscectomy, this results in increase of contact stresses to the tune of 235%. So for these reasons, and to prevent the osteoarthritis, it is very important that attempt should be made to repair the meniscus wherever possible. The considerations which you must consider before undertaking a meniscal repair are the location of the tear. The tears which are in the red zone, they are better amenable to repair. The configuration, the longitudinal tears, the bucket handle tears, they heal better. The length of the tears, the shorter the tear, the better is the healing. And how much stability the meniscus provides to the knee joint, and whether the tear is acute, and what is the age of the patient. So all these factors contribute to the healing process in meniscal repair. The principles of repair one must follow in each and every case, and they are ABCs of the meniscal repair, that is the anatomical reduction, the biological preparation, and the circumferential compression. Another important factor is the consider, especially on the medial side, is the pie crusting, where the MCL is gradually lengthened by inserting a spinal needle and gradually elongating the MCL. This allows you to approach the posterior horn of the meniscus in a tight knee and avoid the cartilage damage which can otherwise occur while attempting a meniscal repair. So this is a very important technique which must be used in each and every tight knee. Again, bone marrow stimulation helps in release of growth factors and must be done in every case where there is an isolated meniscal repair. When it is associated with ACL, it is perhaps not required because you are already making tunnels. So we present a case of 47-year-old male who sustained a twisting injury to the right knee and then complained of pain and swelling on the inner side of the knee. Clinical examination showed a medial joint line tenderness. The McMurray's test was positive. The cruciates and the collaterals were intact. The MRI finding, you can see there was a horizontal tear of the posterior horn of the medial meniscus, and this is the surgical video. You can see the horizontal component, and as is the principles of meniscal repair, the tear has to be cleaned and shaved so that you promote vascularity in this area by using a shaver, by using a rasp, by inserting needle so that the local blood supply improves and contributes to the meniscus healing. So this patient came a bit late, so there are a lot of cartilage changes which have already set in. So once you have prepared the meniscus, the next step is the repair, and for that, for this horizontal, we use the all inside meniscal devices, and they provide circumferential compression with one end going upwards and one below the meniscus, and you achieve a circumferential compression. So depending on the length of the tear, 4 to 5 anchors on an average are used for repair of a horizontal tear. So we are second anchor now going in position. One is above the meniscus, one is below the meniscus, as you can see, and this provides a good circumferential compression. So earlier these horizontal tears, they used to be resected, partial meniscectomy, which resulted in increased contact stresses and osteoarthritis. Again, coming to the anterior part, we changed the angle, we take the scope into the medial portal, and from the lateral we are inserting the anchors in a similar manner, superior and inferior to the meniscus tear, and achieving circumferential compression. Again, very important while inserting these anchors is to avoid any damage to the articular cartilage. So one must go in safe planes without injuring the articular cartilage. So many times this probe is used to guide the anchor below the meniscus, as you can see, and again good circumferential compression. So these anchors must be placed at a distance of 4 to 5 millimeter in order to achieve a robust compression. So in this case, as you can appreciate, we are using this is the fifth anchor. Again, probe is being used to guide the lower anchor into its position, and this is again tightened to give a very stable configuration to the. So as you can see, this is a very stable construct now. So in conclusion, one must save as much as meniscus as possible. Remember the ABCs of meniscal repair, that is the anatomical reduction, biological preparation, and circumferential compression, and all inside devices work very well in our hands. Thank you very much for your kind attention.